This next video we'll be moving along in our terms to know in our spine unit, and we will be covering the terms of kyphosis, Sheurmanns kyphosis, a Schmorl's node, and Lordosis. So we'll be covering those four right there. Before we get into kyphosis, I wanted to just start with another general principle, and these are the degrees in the development of a deformity. So we have a first, a second, and a third degree, and these are just general principles that you guys can use to know the severity of the degree, and this is a basis that we can use as non-practicing doctors, right? That we can just say, well, is that going to be something that is fixable with this, or are they going to need this, right? So something that is a first degree deformity is going to be curable by exercise. These are going to be some of our postural deformities where, we're just sitting at a desk all the time. So we develop rounded shoulders, we develop really tight hip flexors. It's nothing that can't be fixed, but it's something that we need some exercise to help us get out of it. So we would call that a first degree. Again, no bony changes. The patient can correct the position affected. Obviously, this is going to exist on a continuum, and so a person can be a first degree at one time, and if the problem persists, it could develop into different degrees. So our second degree is improvable by exercise, however, not curable. So you may have some contractures, you may have a slight degree of bony change, but if that person goes in and starts to develop some rehab, and rehab protocols and really become strict in those, we can often treat things or improve things through exercise. One example that we'll get to later is when the chest has started to sink in, a pectus cavium. So sometimes if the chest has not sunk in or the person is still growing, a lot of times the doctors will have the patient start doing a lot of pec exercises, a lot of opening up exercises, a lot of back exercises, especially in someone that's growing. So it's not going to be something that's curable, but if they do enough exercises and they develop enough strength, it's going to help open the chest up instead of having a nice caved in chest. So a second degree is something that is improvable by exercise. And then our third degree is going to be something that is affected enough that even if you implement a hard exercise regimen or regime, then it's still going to be unaltered. Obviously, the big key here is there's going to be a lot of those bony changes. So oftentimes exercise may improve someone's condition. It may make them feel better, but it doesn't always directly translate into helping fix the problem. So that's what a third degree is. Oftentimes we'll talk about this surgical intervention for a third degree, especially in the spine. If it's bad enough and it's causing enough problems in the body, in a third degree case, it would require surgery. So let's get into kyphosis. So what is kyphosis? Remember, all of us in our spine should have some kyphotic curves through the sacrum as well as through the thoracic vertebral region. So all of us should have some kyphosis, but when we experience excessive kyphosis, it can become pathologic. So symptoms of excessive kyphosis, it can just lead to an unattractive posture. It could potentially lead to pain, especially during movement, if it becomes severe enough. Again, depending on the degree of the deformity, we could eventually develop some pressure on the heart and the lungs. Maybe someone feels like if they can't catch their breath, trying to breathe hard because there's not enough space in the lungs because of an excessive kyphosis. So there's definitely a continuum here. You can see this is a fairly significant kyphosis. I don't know if this degree here would be enough to restrict lung or heart function. However, I think that would take a pretty drastic angling that really is limiting the amount of space here in the upper thoracic region of the body. Yes, a severe curve can also lead to some of that radiculopathy If you decrease that intervertebral foramen, I hope you can begin to imagine a scenario where if you limit that enough and then you introduce some lateral flexion or some extension, essentially you could induce a radiculopathy because of a kyphosis. So when we look at these, obviously there's going to be the different degrees of kyphosis. We're going to diagnose this oftentimes with a forward bend test, and you're just going to see, if you don't immediately see it, you may see it in an Adams forward bend test where you see the big hump begin to develop. And that's going to be this abnormal vertebral structure. You're going to be able to flex down here, but you probably won't be able to move as much. More bony structure is going to be up here. So you can see here in this individual, we have the x-rays here, where a person has a degree of kyphotic curvature. It looks like here this is an 85 degrees. They've gone in and done a large fixation throughout the vertebrae, and they have decreased the amount of kyphotic curvature in this example. Realize, I want you to just pause for a moment and appreciate the amount of life-changing circumstances that are going to exist if someone chooses to undergo this type of a procedure. You're going to take away all of the motion through these vertebrae that have been fused. You're going to limit rotation. You're going to limit flexion, extension, lateral bending, right? I want you to just appreciate the amount of life-altering circumstances that will now exist in this individual going from this to this. So obviously this person felt like their kyphotic curvature was bad enough that they needed to have this done. A lot of times this will be pain-causing, pain-induced. Before I move off of this really quickly, just a note about this the Cobb angle. I actually took a second and looked this up. Here it is. So with the Cobb angle, we're actually going to talk about this in scoliosis as well. What this Cobb angle is, this is simply identifying the vertebrae at which the deviation begins. So the first vertebrae where you really feel like you can see the deviation, that is where you create your angle, and that is what you're going to use to identify the degree of curvature in that spine. I don't recall anyone saying that they wanted to be a radiographer. I'm sure in radiography this becomes more refined than this method that I just told you about. However, just so you know, as a general circumstance, this Cobb angle is the beginning of the deviation in the vertebrae, and then you measure that angle from there. So we'll come back here. You can see some more examples. So I feel like this example here is a, if I'm looking at it, yes. This example here is a really drastic kyphotic curvature with the surgical fixation. You can see here another example. This one seems to be up a little. It's more superior in the back. So you can have that kyphotic curvature occur anywhere, anywhere in the back, especially in this thoracic region. It looks like here we've got a brace that someone may use to help limit the amount of kyphotic curvature that exists. This would be an example of like a second degree kyphotic curvature, right? Where it's maybe improvable with exercise or some bracing, but it's not all the way relieved. Okay, so moving on, some different kyphosis types. So the first one that I'll just mention these four. I've got an image that we'll go to, and realize this was Dr. Johnson's note here. He asks you not to be able to understand these all separately, but to understand kyphosis generally. So realizing there's some different types of kyphosis that exist, and I'll demonstrate these so that when you get asked about them, hopefully you can identify these different types of kyphotic curvatures. So the first one is a round back or a sway back. You see there. I think sway back is the common term that I learned more often, and it's also the one that I hear more, but that might be clinician specific. So the big thing on the sway back or the round back, you're going to have decreased pelvic inclination. So we're going to have a little bit more of a posteriorly pushed pelvis, and we're still going to have that thoracic kyphosis. The next one is this humpback or just a gibbous. This is a sharp posterior angulation. That's like what we saw probably here. This is probably a nice gibbous example where they have the lordotic curve, but they have a very nice angle right there exhibiting kyphosis. The next one is a flat back. So we're going to have, again, this time a posteriorly rotated pelvis. That's going to take away the lordotic curvature in the lumbar spine, and we're going to have still a nice kyphosis through the thoracic spine. And then the last one is a dowager's hump. Chances are you've seen a dowager hump. It's especially apparent in postmenopausal women, and it's often associated with some osteoporosis. So a couple images here of these. I'll move this here. So in image A, we've got this ideal alignment. Image B, this is a kyphotic lordotic curvature. So this is going to be excessive on both sides. They have excessive lordosis, excessive kyphosis. I think we'll see this in the lordosis slides. This is that flat back. You can see that pelvis is rotated posteriorly, taking away the lordotic curvature through the lumbar spine. However, they still have a kyphotic curvature in the thoracic spine. So we would say that this is a kyphotic curve. And this last one is the sway back. So we're going to have the pelvis. I think I might have misspoke. So the pelvis here in this image is pushed anteriorly. It's pushing the thoracic spine posteriorly, contributing to excess kyphosis, if that makes sense right there. Okay, so take a look at this image again. The pelvis is pushed anteriorly. You can see that on the plumb line. The pelvis is pushed anteriorly, really accentuating their kyphotic curve in their thoracic spine. Okay. And then we're going to keep on moving here. So we can see some degree of deformity here. You can look at this and think, is this going to be a first or a second or a third degree kyphotic curvature? Hopefully you look at this and realize that this is bony changes that are not going to be fixed by exercise. Obviously this person's life could be, their quality of life may be improved by exercise, but no amount of exercise will eventually take away this kyphotic curvature here. This next one, this is a kyphotic curvature due to a different reason, and I think that's why they threw this picture in with this slide. Dr. Johnson threw this in. This is a extra thoracic vertebrae in a wedge shape, and it's causing this kyphotic hump. So you can have instances where maybe there's an extra bone or a misdeveloped bone, or we'll come to the examples next. Maybe this bone didn't develop normally throughout the person's life, and that is what will contribute to the kyphosis. So many different types of examples that we may see in this kyphotic region here. Okay, so our next one, if anyone out there, I assume this is German. I'm probably butchering this. I call this Sheurmanns kyphotic curvature. So this is a very specific type of pathology which is going to contribute to kyphosis in the thoracic spine. So often the onset is in young people. It's predominant in males, and they may or may not have pain. It just depends. So what I read about in this, I actually never treated anybody with this, and I haven't known anybody that has it. However, what I read about in this is the posterior sections of the vertebrae are actually going to grow faster than the anterior sections. Let's go ahead and see if we can see that here. So these anterior sections are not going to grow as fast as the posterior sections. And so what ends up resulting is you have a kyphotic curvature throughout the spine, which then is going to develop more and more and more throughout a person's life. So I think if we come back this, as someone gets older and they have this Sheurmanns disease, eventually it will come to a point where it may limit them more and more and more. So coming here, this is a 22-year-old male that had this. He had a 13-level spinal fusion. So again, just realize what the person is going to be sacrificing in doing this, but they I think it's obvious to see in this amount of kyphotic curvature that this person is going to be most likely experiencing some significant pain. It's probably going to be altering their life significantly and maybe even compressing and compromising lung and heart function, as we talked about a little bit earlier. The next one we're going to cover is a Schmorl's node. Schmorl's node. So a Schmorl's node is really simple. A Schmorl's node is simply a protrusion of the disc into the vertebral body. That's all that's happening. So you can see here a disc is going to protrude into a vertebral body. Some type of deficit is occurring in the bony structure, which is not keeping that disc in place. And the disc will overcome the bone's ability, and it will eventually push up and disrupting bony structure. That's all a Schmorl's node is. So a note down here, Schmorl's node have often been associated with people that are experiencing other types of spinal deformities as well. And it's really unclear if these, the chicken and the egg, if these contributed to the pain or if these were secondary to the pain. It's, as far as I can understand, it's still unclear. So you can see some Schmorl's node again here, just a few more images. I think we have a few more slides on this. This is the distribution for Schmorl's nodes at each vertebral level, T1 through L5. You can see that the majority of them are going to exist right at the end of this thoracic region into the L1. Realize the further down on this graph we go, the more weight the vertebral bodies are going to be asked to carry. So I think that that's an important note in the Schmorl's nodes, and probably a very likely reason as you move down that we start to experience more. And then there's something in the lumbar regions, especially this L4 and L5, where this is the region where we see more disc herniations, but up here we're going to see more Schmorl's nodes. So there's something up here in this end of the thoracic region into L1 that is going to contribute to loss of bony integrity, and those discs are still going to be very strong. They're going to be very compact because of the amount of weight that they carry. And then our last image here of these Schmorl's nodes. So again, we're going to have a bony defect. Oftentimes you can see this bright white on this radiograph. This is going to be bone growth. So the vertebrae are just going to come in and they're going to remodel this bone. Hopefully they're going to push out or recycle the protrusion of the disc, and they'll hopefully reform these vertebrae over time. I think there was a note. Oftentimes Schmorl's nodes may or may not be symptomatic. There it is. They may or may not be symptomatic, and it just depends on the individual's degree of pathology with those Schmorl's nodes. Finally, for this video, lumbar lordosis. I want you to remember, having lordosis is in and of itself not pathologic. All of us should exhibit some amount of lordosis, especially in the cervical and the lumbar spine. However, if we display excessive lordosis, it could potentially lead and contribute to pathology. So you can see here a normal lordotic curvature and then an exaggerated lordotic curvature. Okay, so you can see here some possible reasons for this excessive lordotic curvature. It wouldn't surprise me if you've known somebody or seen somebody that begins to display excessive lordotic curvature. A lot of times that person will feel uncomfortable, and we'll see that in the coming slides. So they may have a postural or functional deformity. They may have some muscle problems, a heavy abdomen, or pregnancy. This is the one I was alluding to. I assume most of us have probably seen this excessive lordosis due to this type of thing. We may also have some bony problems, and then obviously sometimes people display an excessive lordosis through a fashion like those high heels. I think we'll talk a little bit more about that through this back unit. So with the lumbar lordosis, with the heavy abdomen or pregnancy, a lot of times what's going to happen is you're not going to initially have this lumbar lordosis, but as the person gains weight in the abdomen, for whatever reason, you're going to see the pelvis begin to tilt anteriorly, even more than usual. That anterior tilt of the pelvis is going to pull the lordosis of the lumbar spine forward, and it's going to create excess lordosis. They have created some bands like this, or some pants. I remember my wife wore some pants that helped support the belly, especially as you get into that third trimester. Or if someone just has excess weight, a lot of times they'll display excessive lordosis as well. A few of the causes there, we kind of mentioned at a few of those. The pathology, this anterior pelvic tilt. So the hip flexors are going to get short and tight. The back muscles are going to get weak and lax. And I think that's what we're going to say about that. You can obviously have some type of muscular imbalances or muscular deficiencies or spinal deficiencies, neuromuscular deficiencies, which may contribute to a lumbar lordosis. Just like everything else, this could be very multifaceted in its etiology. And that finishes this video that covered lordosis, kyphosis, Schmorl's nodes, and Sheurmanns disease.